so many colleagues. Okay, I'm going to start slowly because I'm very certain that there will be lots of questions for Melissa. So I will introduce slowly while people continue to join. It is my pleasure to start us back in terms of the fall webinar after a summer break with Melissa Snider-Adler talking about the ABCs of drug testing, understanding what a test can and cannot tell you. Next slide, please. I'd like to start us off with our Medify land acknowledgement. We acknowledge that the lands on which we're hosting this meeting include the traditional territories of many nations. The work of Medify and our partners takes place on traditional territories of the Indigenous nations who have lived on these lands since time immemorial. Medify is located in Toronto, on the ancestral homelands of the Huron-Wendat, the Anishinaabeg, the Mississaugas of the Credit, the Haudenosaunee, and the Achewenderons. This is Dish with One Spoon treaty territory. Medify is committed to reconciliation. We recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. We respect and embrace the rich cultural and traditional practices of the ancestors. We invite our partners to reflect on the territories where they are situated and to join us in committing to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. Could I have the next slide, Lori? Thank you. So a reminder to everyone, I see the chat is going with introductions. Please make sure that you select everyone in the chat rather than host and panelists, unless you need to send a private message. Feel free to post thoughts and questions as they come up. I'll be collating them, and I'm sure that we will have time for questions and answers at the end of Melissa's presentation. If you want to ask your question yourself, if you put your hand up during the last 30 minutes, Lori can unmute you, and that will be an opportunity for a little bit of direct dialogue with Melissa. Please remember to complete the evaluation at the end of the session. That's really important for us in terms of feedback, especially as this session is accredited with the CFPC and the Royal College. Of course, a thank you to our webinar series committee members who've helped to brainstorm and create the content that we present. So it's my pleasure to introduce Melissa, who has many letters after her name. I'm not going to say them all. Melissa Snider-Adler is an addiction medicine physician, medical review officer, assistant professor, and co-author on a review paper and book chapter regarding medical cannabis and impairment. She's provided extensive expert testimonies and reports in Canadian hearings and court cases. With a passion for education, Dr. Snider-Adler regularly speaks at conferences on fitness for duty, workplace substance use, medication safety, drug testing, and addiction prevention and treatment. And you may know her because whenever there's a question on the listserv about a urine test result, she'll pop up with the answer that we're all looking for. So it's a treat to have her here sharing. I will step back and let you take it away.
Thank you. Thanks for the introduction. And thank you everyone for joining. It's nice to see such a big crowd. So I'm just going to share my screen. One moment. Okay, so I will absolutely leave time at the end for questions. And we have a lot to go through, but really what I want to do is, I'm not here to advocate for drug testing or anything like that, but we're all doing it as part of our clinical, or many of us are, as part of our clinical practice. And really the important thing is understanding what it actually means, what kind of tests we're ordering, what we should be ordering, what we shouldn't, et cetera. So we're going to go through all of that. Here are all the objectives, which I'm not going to read, but essentially we're going to go through everything you need to know about drug testing, the results, interpreting them, and whether you should be sending them to the lab or doing them in your own office as a POCT. So we're going to talk about all of that. From a disclosure perspective, I am the Chief Medical Review Officer at DriverCheck. DriverCheck is a third-party administrator for alcohol and drug testing in the workplace. not involved in clinical testing at all, but it is about drug testing. So I wanted to put that out there. And I have done presentations and received honorarium from Indivior and Master Clinician Alliance, more from an educational perspective, but nonetheless. All right, so when it comes to substances and substance use, I think we all have a really good understanding of what we're doing from a day-to-day basis, but substance use definitely comes into play in, drug testing comes into play in what we do to really manage our patients. Or to counsel our patients. And there's many reasons why we do drug testing. So going through an understanding is really important. I put this up here, one, because I find it funny, and also because it is the reminder that drug testing is a piece of the puzzle. It should never be used from a punitive perspective, although often in certain circumstances it is. And so I really want to go through so that we're understanding what we're doing, understanding what the results are actually telling us, so that when we are counseling, discussing, or providing the information to a third party, that we know what we are sharing and really what it all means. So for us in clinical practice, drug testing is often used from a diagnosis perspective, from guiding treatment sometimes. I think about in an emergency department, for example, if somebody comes in and they want to do a tox screen and see what may be going on, we will sometimes use it to corroborate information. And most importantly, from a counseling perspective for our patients, which I think really provides from us from a clinical perspective, the most important reason why we're doing drug testing, to be honest. But there are many times, even though we're doing this clinically, that the results that we are using and or sometimes the reason why we're doing testing is for a third party. For example, CAS. I will often have CAS workers ask me to send them the results of a patient, obviously with signed consent. We wouldn't send it otherwise. We're going to talk a lot about that as well, because I'm sure I'm not the only one that gets that request. Sometimes things like person may have lost their driver's license and you have to fill out a form to say that they're not using substances anymore. You may want to confirm that first, so we may be sending tests away for that reason. And sometimes it has to do with the workplace. And so these are all the reasons why we may be doing drug testing. Maybe there's some other reasons that each of you have, but those are the main ones. There are many different ways to do drug testing. Obviously, we do not do many of these in our office, but they all tell us different things, and they all have different timeframes of detection. The only one that I'm really going to be talking about today is urine testing, but if you have questions about any other testing, I'm more than happy to answer them. But for the most part in our offices, it's going to be urine testing that we're doing. So that's what I'm going to be concentrating on. So urine testing has for many, many, many years been the gold standard of testing from a clinical perspective, in the hospital, in Emerge. We do sometimes do blood testing, but generally speaking, it's urine. The problem with urine, and even in our clinics, and even if we are observing, I put observing in quotations because it's not, sometimes it's over a camera, sometimes it's not. But nonetheless, there are two issues with urine testing that we all need to be aware of, and we probably are, is tampering, or what we call substitution, meaning bringing in fake urine, or adulteration, adding water to the sample, etc. It is shocking to me how many times I've had to discuss this with patients of mine when I really make it very clear that this is not a punitive thing. It's just for us to have discussions to help me understand what's going on, for us to be able to talk about things, etc. If I'm doing drug testing, then that's what it is. But it is amazing how many times people will have tampered, and then they usually admit to it. But the reason why they do it is not usually I mean, sometimes it's because they have shame or guilt. They don't want you to know. Sometimes their results are going to a family member or a third party. They don't want them to know. These are some of the products out there. There are many more. The Wizinator is my personal favorite. It comes in every kind of skin color you can imagine. It now comes with a bladder where you can fill up fake urine that you can buy with it and heat it up to the temperature that you need. And sometimes that heating does not work. And so you get very hot samples or cold samples. And sometimes they borrow it from somebody else and the skin color is completely off, which I have seen. The other one is an M&M container, and I don't know how many of you have seen this in use, but essentially my female patients have filled this up with urine, sometimes of their children or their spouse or their friend. They put it in the vagina, and if they just click it, then the urine comes out. So it is shocking to me, even in our clinical practice, excuse me, how many times this happens. So it is just something to be aware of. It's out there. Talk to your patients about it. If the temperature's off, if you're doing temperature testing, if the staff says, I think this feels cold. If, for example, they're prescribed something and that's not showing up on there, it's interesting to have this conversation with the patient, and in a non-judgmental way, you will usually get some very interesting concerns and reasons why they've done that. But when it comes to drug testing, with respect to what we are responsible for as a healthcare provider, there are 4 components. So one is the collection. And in our office, it's either observed if you have cameras, and then you do observe testing, or non-observed. From a forensic world, and what I mean by that is when we're doing workplace drug testing, or for any other forensic reasons, really what truthfully CAS should be doing, and not relying on our results, but that's another story. Forensic testing involves chain of custody, and essentially that means that there is paperwork and follow through from the moment a test is collected all the way through to when it's reported back to the healthcare provider who's ordered it. Our labs provide medical testing, which they do differently than their forensic testing. And understanding a little bit of the difference, I'm not going to go into a lot of the differences, but understanding the difference, there's specific paperwork, and there's different cutoff levels, and there's different reporting and different kinds of testing that the lab uses when it's forensic versus medical. What we do in our offices is always considered medical, and we'll go through, when you send it to the lab, what that actually looks like. So at the lab, every test you send will be screened and confirmed, or most urine tests are screened and then confirmed at the lab. The confirmation is sort of the confirmation that the substance that you are testing is actually present. The lab gets a quantitative level. They don't always report it in a medical perspective. So they do from a forensic perspective, but not from a medical, but they always have a quantitative level for most substances, not all. It gets reported to us as healthcare providers. The lab then stores it, and depending on whether it's negative or positive, they store the sample for different lengths of time. We then, it's our responsibility, since we're ordering it, to review it if it's coming from the lab and interpret it, and then take action. So you need to understand what that all means. So let's go through a little bit about all of this. So POCT testing is point of care, or it's also called point of collection testing, on-site dipstick testing that many of us use in our clinics. They are great, but they are not perfect. And understanding why they're not perfect and how they work is really, really important, so that when we are looking at the results, we really can talk to our patients about what we're seeing. And when it's not in agreement with what they are saying, we can have different answers or reasons why. So sensitivity and specificity of a test, meaning, false negatives, false positives, the rate of that, how often we're having something test positive due to something else, how often we have something test negative, even though the substance is there. And I will tell you that there is no POCT test that is 100% accurate, meaning we will get false negatives, especially in and around the cutoff levels. So every POCT device, and we may all be using very different ones, and that's fine. Every single one for each substance has a cutoff level. It is not 0, it's not even 1. It differs based on the substance. You can find out what it is if you're interested by looking at the specific product that you're using. And in that product comes a product insert. It's a piece of paper. It has all of the information in there, or you can look it up online. And essentially, with the POCT test, if it's at the cutoff level or above, it's going to show as positive. And if it is below the cutoff level, so there still may be substance there, but it's below that cutoff level, it will be reported as negative. If there's a substance in and around the cutoff level, it can sometimes be reported negative, even if it's there. So sometimes you may see a negative test on a POCT, and if you happen to send it to the lab, you may see that it's positive and wondering, well, why? And that's one of the reasons, is that it may not have detected it because it wasn't very high levels. The other thing with POCTs, and this is where I've jumped in some of those questions on, through the emails and the listservs, is cross reactions. Like, why am I seeing a positive for this when they're not taking that, or they said they haven't used that, et cetera. And for a screening test, essentially, when it's a POCT and when it's a screen, it's the same thing at the lab. It is not that one particular substance that it is only looking for. So for example, let's talk about cocaine. So the cocaine in the urine, we are looking for the metabolite called benzylecgonine, which is the main metabolite of cocaine. However, in those POCTs, there's a whole list of different substances related to cocaine metabolite or cocaine that if any of them are there in combination, that will then add up to be above the cutoff level, it may be positive. And I'm going to show you what some of this means and what I mean by this, but each POCT is basically a group of substances of related substances. So amphetamines are the group of amphetamines, and they may include methamphetamine, MDMA, MDA, MDEA, and a number of other metabolites or substances that look like amphetamine. And same with all of them. So what we are seeing sometimes is not always what the drug test tells you that it's positive for. It may be for one of the other things that cross-react or that is related to that substance. Some of them are more accurate than others, and it depends on the substance. So we have higher accuracy, truthfully, for fentanyl and for cocaine. If you see a positive, it is likely to be a positive. That doesn't mean that there can't be a false positive, but if we see it as positive, that's generally what it is, but it is very dependent on the device that you're using. So when you look at that product insert, and this is really hard to see, I have a couple that I'll show you kind of more close up, but every product insert will show you each group of substances with different cutoff levels, because often different devices have options for different cutoff levels. So you should look to see which one you are using. Often we don't know, like they're just purchased by somebody and we don't necessarily know, but it is good to know. So I would encourage everybody to look into that. But you can see, and I'll turn to the next one just so that you can see here what I'm talking about. I just pulled out two, one for fentanyl, one for methamphetamine. The reason why I have two there, the ones that kind of are darker or more bold, are from one specific product and the others are from another product. And what you will notice is that they are different. The cutoff levels are sometimes different. The cross reactions and the substances that cross react with that particular result are different. And the levels at which they cross react are also different. So if you see the numbers, let's look at fentanyl, for example. On this particular fentanyl dip, if fentanyl is present at 100 nanograms per mil or above, it'll result in a positive test. If norfentanyl is 20 nanograms per mil or above, you will also get a positive test. If we look at the other device, it's different. The cutoff levels, it will detect fentanyl at 10 nanograms per mil and above, and it will not pick up norfentanyl unless it's at 50 nanograms per mil or above. And interestingly, the first one, that if you look, you see a few different substances, medications in some case, and fentanyl analogs that will cross-react, and that will result in a positive test. Okay, so buspirone is one interesting one. So I know I said that generally speaking, when it says fentanyl, it is fentanyl. Buspirone on this particular device will result in a fentanyl positive. And I had one patient prescribed buspirone who ended up testing positive on fentanyl. And that's when I realized that that particular one cross-react. The other one that we use in my office, which is the one that's below, doesn't. And so when we did it on the other dip, it was negative. And when I sent it to the lab, it was negative because he wasn't using fentanyl. The other interesting thing is that we are sometimes seeing, and we'll talk about this as well, that fentanyl is not always fentanyl. And what we are seeing in the kind of fentanyl that our patients are using are more of the related substances, analogs, metabolites, et cetera. And so I had a patient who came in telling me he's using fentanyl. He clearly looked like he was in withdrawals. There was no question about opioid withdrawals there. And his fentanyl test was negative. Actually, all of the opioids were negative. And, so here I am thinking, okay, this clearly looks like withdrawal. He had told me that he had just used like earlier that morning, so it should test positive. And when I used the other device, because we have two different ones, it showed positive. So probably what he was using didn't have a lot of fentanyl and norfentanyl in it. That would then break down to norfentanyl, but maybe it was alfentanyl, sufentanyl, et cetera, that tested with this particular one. So just interesting things to look at. But again, it very much differs from device to device. I will bring up one that Jennifer and I were talking about before that I wasn't even aware of until I looked just now. But for your patients who are taking or prescribed hydromorphone, some of the oxycodone dips, like the tests, the POCT tests, will cross-react with hydromorphone. And even if they are not using oxycodone, oxyneo, any of those may test positive for oxycodone because of their hydromorphone prescription or hydromorphone use. I didn't know that because that's not something that I often see or come across, but when I looked it up, it was right there. And again, it may depend on device to device. So your device that you're using may not cross-react with that, but others may. And that's why it's important to know what we're looking at. Ephedrine for the methamphetamine is a big one. I have a lot of patients that are using ephedrine. And so they will sometimes show up positive for methamphetamine due to their ephedrine use. Not methamphetamine, it's ephedrine, but again, that's where the counseling comes in. That's where we may decide to send it to the lab. So let's talk about lab tests for a moment. When you send it for the lab, as I said, they usually do a screen and then a confirmation. They do have specific cutoff levels, but depending on the kind of test that you're doing, the cutoff levels may be very different. So, and we'll go through this, there are different ways of sending, from a medical perspective, sending a urine test to the lab. There's different types of tests that we can order. And depending on what we order, they will have different cutoff levels. And we'll talk about why that's important. They also have different lists of things that it tests for. So you can get quantitative levels. You have to ask at the lab for it when we're ordering medical tests, but they will provide it to you. Generally speaking, we as, like from our medical side, can request at the lab what they call drugs of abuse testing and or what they call their broad spectrum toxicology panel. We're going to go through what the difference is so that you can understand it, because there may be different times where you send one for broad spectrum and you send another patient for drugs of abuse. And so it's important to know why we do one or the other and what information we get out of it. So first, let's talk about why we're even sending it to the lab. Like, why not just only do on-site testing or POCT testing? I will often say when there's a discrepancy between what the patient reports or what we know to be true and what the POCT says, if it matters, sometimes it doesn't matter. If it matters, send it to the lab. And sometimes, truthfully, like I will say, it's okay. I believe you. Like I'll sometimes say to the patient, if it tests positive for one thing, but they are telling me they're using something else, I will say, look, it could just be a cross reaction. It may be a contaminant in something that you're using. It's okay. But they're so caught up on, well, I need to know if it's in my body or not. And so then I will send it to the lab just to give them that information. Sometimes from a counseling perspective, I like to send it to the lab when they're using one substance. And I feel like when they know about all the contaminants that they're in there, that may help from a counseling perspective. I may send it to the lab. We will sometimes do this with medication compliance. So if we're prescribing, benzodiazepine or an opioid or something else, and we want to make sure they're not using outside of what we are prescribing, or diverting it for that matter, we may decide to send it to the lab to see specifically if that particular substance is in their urine. So, for example, benzodiazepines. Let's say that I am prescribing clonazepam and I'm concerned that they're getting a prescription from somewhere else or they're using outside of the prescription. And we've, maybe had a discussion about this before. If I use my POCT, it's just going to tell me that the benzodiazepines are positive, which they should be if you're prescribing a benzodiazepine. If you send it to the lab, though, you can see which benzodiazepines are positive. And so that may help you, again, from a counseling perspective, from a discussion perspective with the patient. You can get the exact one. Is it clonazepam? Is it diazepam? Is it temazepam, oxazepam, lorazepam, et cetera? And so when you send it to the lab, you can get the exact opiate, the exact benzodiazepine, the exact medication that you're looking for in that result. We sometimes send it to confirm abstinence. Sometimes that's important in clinical practice. Sometimes it's important for the patient for other reasons, what I call third-party reasons. Maybe it's parents, maybe it's spouses that need to know, maybe it's CAS that needs to know, maybe there's a legal case that they want to know and show that they haven't used anything. Maybe it's just for counseling with us, et cetera. There are lots of reasons why we send to just confirm that the only things in their urine are what is prescribed, and that it would be another reason to send it to the lab. There will not be a test on this, but this is an example. This is Dynacare's broad spectrum toxicology panel. So if you're using Dynacare and you send your urine and it goes to Dynacare and you send it for, you may call it a toxicology panel or a broad spectrum tox panel. If you send it for that, it is literally going to test for and confirm a whole list of substances and medications. So it is very long. I'm not going to go through everything, but just for you to see that if you want to know about, I don't know, an unusual medication, you want to make sure they're taking it, or you want to see exactly what they're using or what's in their urine, like maybe again to have a discussion about the contaminants, then you can send it for a broad spectrum. It does not give you a quantitative level. It will only tell you that it confirmed positive for one of these many substances. That this is all of them. It's very long. And when it does that, when it confirms it and when it shows you, and it may say, for example, methadone, EDDP, I'll often see the methamphetamine, cocaine metabolite, which is benzoylecgonine, diazepam, nordiazepam, trazodone, et cetera, et cetera, et cetera. You get this whole long list of what it's positive for. You see below what it's tested for. At the bottom of that broad spectrum toxicology panel report, and this is from Dynacare, it has this little notation, and it says that essentially that you can look online and you can see everything it's tested for and the specific cutoff levels that they use. So for many years, this was really not really important, because often we would just see it positive and the patient would tell me they were using something or they weren't, and we would have a discussion. I will tell you how this became, how I started to realize and notice this. I had 2 or 3 patients who we would send their urines periodically to the lab, and then the CAS was involved in the care of their children. And, I'm testing them at my clinic. They're never testing positive for cocaine or cocaine metabolite ever. They're telling me they're not using, they're doing really well. We have, like, they come in for appointments, they look great. I get a sense they're not using anything. I see them enough, and I've been seeing them for many years, and I was, treating them and seeing them when they were using, and I can see a difference. And so from my perspective, they haven't been using any cocaine. I believe what they're telling me. My test at the clinic is negative, but every time I send it for a broad spectrum toxicology panel, it's coming back positive from the lab. And I'm thinking, I'm like losing my mind. Like, why are these positive? And they are swearing up and down that they're not taking any or using any or around it, etc. So I just happened to go on to this link. And what I noticed, and it shows literally every single substance they test for. They tell you what it is. They tell you the interpretation. They tell you the urine detection time, although don't go by that because it's actually not right, but that's okay. And they tell you what this new level of detection is. So in the last couple of years, they lowered their cutoff levels for the broad spectrum toxicology panel to very, very, very low cutoff levels. I'm going to show you one, and that's the benzoylecgonine, the cocaine metabolite, just to kind of prove my point here a little bit. I just made it a little bit bigger. So benzoylecgonine, cocaine metabolite, main metabolite of cocaine. It will stay positive much longer than 1 to 2 days. And they use a cutoff level of 10 nanograms per mil. So in the forensic world, we use a confirmation cutoff level of 100 nanograms per mil. And why is that? And I'll go through some of this, and I have a slide that shows you the studies and the research, but I'll just talk about it a little bit now as well. We cannot confirm below a certain level, below 100 nanograms per mil, that the positive test is due to personal use of cocaine. I'm using cocaine because that's what we're talking about here. But we can say the same thing with methamphetamine. And so at first, most people will think, oh, the lower the level, the better, because then I'll see if there's anything in their system. And yes, that may be good. Maybe I'd be missing it if I use a higher cutoff level. The truth is, though, is that there is cocaine in a lot of places. In a lot of our patients' homes, other people may be using cocaine. It is true, there is cocaine on money. There's been lots of studies. There's cocaine on, if you go on the subway, if you were to swab any of the surfaces on the subway or on a bus or on a railing in a public place, they often have low levels of cocaine. It's not enough to get in our system and result in anything, but it may be, especially if you're living with somebody who is using cocaine, be enough to result in a positive test at 10 nanograms per mil, but below 100, okay? So what I started doing once I realized this is that I asked the lab for the quantitative levels for these particular patients. I had one patient whose youngest son, and again, was doing really well, had gone to counseling, was seeing me almost every week or two just because she wanted to. Her youngest son, CAS, was going to put him up for adoption, which is a huge impact for somebody who, is like absolutely, completely saying to me she has not used any cocaine. She's away from it. She, all of that. So we get the quantitative levels and they're, 12, 15, 20, 10. Those are the levels. And I said to CAS, I can't tell you like if this ends up going to court, you're going to get somebody as an expert, and maybe it's going to be me, saying you can't confirm that she was using cocaine, because anything below and anything at that very low level cannot be necessarily from personal use. And so now we are, really, there's real big impacts and consequences of what I call passive exposure, or secondhand exposure, however you want to say it, when we're using these very low cutoffs. So what I will tell you is, and I'm sure I'm not the only one who's seen this, when you get something back from the lab and it is not consistent with what you were seeing in the clinic on your tests are all negative, or they're negative for something that's showing up positive from the lab, look at what you sent it for and look at what the cutoff level is and talk to the patient. Sometimes it doesn't really matter. Sometimes there's not going to be any consequences, but I feel like there was a little while I was feeling like my patient must be not being honest with me about their use, because cocaine keeps showing up, and maybe they are using, but they're timing their use, or who knows. And that can lead to some issues, right? With that therapeutic alliance, with us, with trust, with honesty, all of that, with our ability to counsel and talk to our patients if we're not believing what they're saying, but certainly secondary consequences with family members, with work, with children, and so with driver's licenses, et cetera. And so look at that. And, just if you are seeing that, you can ask the lab for the quantitative levels, but you can also send it for a different test. So the other option at the lab is what's called drugs of abuse. So this is Dynacare's panel. Life Labs may have a slightly different panel. I tried to get the Life Labs information, but it's not the lab that my clinic sends everything to, so I just wasn't able to get it. But if you use Life Labs or another lab, I don't know if there's any other ones that we generally use here, but if it is, just ask your lab, what it is that you're testing, what your options are if you want to send it to the lab. I know Life Labs has drugs of abuse, and I know that they have broad spectrum toxicology. So you definitely have that option. I just don't know what their panel is specifically. Drugs of abuse at Dynacare is everything that's shown here. It's the big kind of buckets, I guess, of substances, or medications. And it will still tell you what's positive and negative, but they use more established cutoff levels and not those very, very, very low ones where it may or may not tell us anything, or it may not tell us about personal use, et cetera. And so this is an example of the cutoff levels for Dynacare. These are the screening cutoff levels. The confirmation ones are a little bit lower, but nonetheless, you're not going to see a positive test unless there's been personal use. I mean, in theory, there could be inadvertent personal use, but unless it, and a substantial amount is in their body that will result in impairment and concern, you're not going to see it positive. So for some of my patients where I was sending it and seeing these really, really, really low levels, I'm now sending it and it's negative again at the clinic, right? So if I need to send it for the lab for confirmation of a negative test, then I will send it for the drugs of abuse panel. And so, it's just to understand that they tell us different things, and the cutoff levels really do matter. And I know we all think, oh, well, it doesn't matter if they're using a little bit, I want to know. But honestly, fentanyl, methamphetamine, and cocaine especially, you can have passive or dermal exposures that result in very, very, very low levels that they may not notice. They may not have any effects from it. It just may be around and may be there. All right. So let's talk about, just looking at my time, let's talk about interpretation. So we talked a little bit about it in the last section because it's really important to know what you're sending it for. But let's now go through what happens with the tests. Like if you have a positive test, what are we doing? What are we looking at, et cetera. So false positive POCT. How do you know that it's a false positive if you are just doing the test at your clinic? So one would be to look at the device that you're using, ask whoever's ordering it, or if you're opening up a new package of it, to look at that product insert, look at the cross reactions, look to see if there's a medication they are prescribed or something they're taking that's resulting in that positive test. And that may give you your answer. You may not even need to send it to the lab. You can, but you may not need to. When it comes to false negative tests, again, if it's around the cutoff, it may not detect it. If it's really important for you to know, I can't even think of a reason why, but because honestly, if my patient tells me they've used something and the test is negative, I don't think anything of it. I'm not going to necessarily send it to the lab, but maybe you want to, and that's okay. You can. We can't really, there's nothing to look at why it's testing negative. Sometimes it's just a device malfunction. Sometimes it takes a little bit longer to show up. And so, excuse me, maybe when you first looked at it, it looked like it was negative, but then it showed up positive a few minutes later. Maybe again, it was around the cutoff level, but it certainly happens. Again, low quantitative levels may be due to passive exposure or dermal exposure. And I'm going to go through a couple studies just to kind of talk about that a little bit. Contaminants of substance use. Again, I think we're all aware of this, but I'm going to go through that as well. And the other thing is the metabolite of medication. Are we seeing something in the urine that is actually a metabolite of what they're taking that you may not be aware of? So let's go through all of that. So this is passive exposure, okay? In drug testing world, we have cutoff levels, as I said, and anything below that cutoff level, and these are sort of the standard ones that are set from the forensic perspective, not the ones that the lab is setting for that broad spectrum where it's very low. The standard forensic testing has standard cutoff levels, and they're set because there have been numerous studies that have looked at secondhand exposure to things like cannabis, methamphetamine, cocaine. Those are the main ones where you would have secondhand smoke or secondhand exposure that way, or dermal exposure, again, touching handlebars, etc., like the handrail, or being in a house with someone else that's using cocaine, or we do all have patients that have large amounts of substances in their home that they may not be using, but they are selling. And so I will sometimes word that to my patients: are you handling large amounts of whatever it may be, fentanyl, cocaine, etc.? Sometimes we don't really want to know if they really are, but often they'll tell you, yeah, I am around it. I'll just tell them, maybe the positive is due to that. Wear a mask and wear gloves. I mean, ideally, don't deal, but in the world of us kind of talking to our patients and them being honest with us, that is a real thing. So handling large amounts with powder, anything that can be powdered, so fentanyl, cocaine, anything that's sort of powdered like that, we can see some inhalation of it. It can get on the hands. If you rub your nose, your eyes, your mouth, it's going to get in your system. And it can get actually substantially high, to be honest, from that type of very large exposure. But generally speaking, the inadvertent exposure, handling money, I had somebody who worked and handled cash, and they were testing at those very, very, very low levels at the lab, but in our tests at our clinic were negative. And when I sent it for the quantitative levels, they were very, very low levels. But these are there's a few studies that I have a whole host of them. If you want them, let me know. I will send them to you. But essentially, you can test positive at these very, very low levels that at least Dynacare is using for their broad spectrum analysis. Due to being around it or handling it. for those substances. So just really understand that and be careful with what you are ordering and what we're taking from it. But again, if you are seeing it positive in your clinic with your POCT devices, all of them that are out there that we are all use the forensic cutoff levels. They don't use the super low ones that the lab is using. They use the ones where if they're testing positive for cocaine in your clinic, it is not from living with somebody who's using cocaine. It's just not. Or sleeping with somebody who uses cocaine. I get that as well. It's not. There's been enough cocaine in their system that they produce enough metabolite that got above that set cutoff level, that larger cutoff level from our POCT. It's just those lab ones that test at the very, 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 very low levels, almost what we call limit of detection, that you can see that. But again, if it's positive in the clinic on your POCT, there was enough that got in their system that would result in impairment, that would result in the same thing that would result in if you used it yourself. And so these are, again, just for those super low levels. So if you haven't seen this, Toronto Drug Checking, there's a website. You can go to that website and you can look at it. You can choose the drug where it says expected drug. You can choose the dates. I just chose the last 6 months just to sort of see what our fentanyl these days is looking like, what else it has in it. You could go back a year, 2 years. You could look at almost any drug and see. It's interesting. It helps us. So if you're seeing something or seeing you're seeing a withdrawal or a reaction or something that you're not expecting from a particular drug, you can see what may have been in it. Obviously, it doesn't test everything out there. It does samples of it, but it is a pretty good indication of what we are seeing across the province. And interestingly, this is also from the last 6 months, looking at it slightly differently. So the orange is if the drug, like how much of the drug that they're seeing and testing is actually the drug that they think it is. So if someone's using ketamine, they're mostly getting ketamine. Same with MDMA, it's mostly MDMA. But you can see with fentanyl, 100% of the products, 100% of the fentanyl samples that they tested between April and September of this year did not meet the expectation of it being fentanyl, meaning that there may have been some fentanyl in it, but it was very low. It was not the majority of it. The majority was everything else, as we saw in the other slide. Same with heroin and same with crack cocaine. So understanding what may be in the substances that our patients tell us they're using kind of really helps us. So, what I will often see is the crack cocaine testing positive for fentanyl, the fentanyl or heroin use testing positive for methamphetamine, and certainly benzos. I think we're all aware of that. And so I'll just sort of say to my patients, my feeling is if they're telling me they're using fentanyl, then if I ask them if they're using a benzo, they're likely going to be honest with me about that. And when they say, no, I don't use benzos at all, then I talk to them about, well, there is benzo in your system. Often what we're using has benzos in it. This is where the counseling comes in. And especially when they are wanting to stop using fentanyl, I've had some patients have seizures. It's not from the fentanyl or the opiate, it's from the benzos, a substantial amount of benzodiazepines and the very potent ones that are mixed in there, that when they've been using it regularly and they stop using, that they may end up having significant benzodiazepine withdrawals, which can lead to seizures. So I have a few patients who have had numerous seizures while they're trying to stop their fentanyl use. And so we may need to deal with that obviously differently clinically, and be aware of that. But that's why sometimes doing testing in our office or sending it away to the lab is helpful to see what it is in their system so we can counsel them and talk to them, not only about what they're putting in their body and what's in there, but if you are going to stop using, we may want to be careful with respect to this substance or that substance. All right, let's talk a little bit about opioid metabolism. So, for the most part, I think this is pretty self-explanatory. I'm sure everybody knows this. The few that most people won't always be aware of is that a small percentage of morphine will metabolize to hydromorphone. So if somebody has a prescription for morphine, let's just say, and you start to see hydromorphone, that may not necessarily mean that they are using hydromorphone on top of the morphine. If you're able to get the quantitative levels from the lab, that will help differentiate other hydromorphone use, if it's important for you to know, versus the metabolism of morphine kind of down the road to that small amount of more hydromorphone. Hydromorphone should be 1 to 3% at the most of what the morphine quantitative level is. And so if there's not a lot of morphine, you're not going to ever see hydromorphone. It's only when we see these high levels of hydromorphone that we will see high levels of morphine that we will see some low levels of hydromorphone. So again, if it's important that you need to know, ask the lab for quantitative levels. I think that's kind of the codeine. I mean, often when people are taking high dose codeine on those broad spectrum results, you'll see codeine, morphine, hydrocodone, norcodeine, et cetera. You'll see all the metabolites. Again, if you see morphine, it's a metabolite of codeine. We will see it. It doesn't necessarily mean that they're using extra morphine. And then the other one to be aware of are benzodiazepines. And so the big one is the diazepam. So diazepam metabolizes to temazepam, which then metabolizes to oxazepam. Oxazepam we can see even 4 weeks after the use of diazepam. So when and why is this important? You may have a patient who went into medical detox or inpatient treatment center, let's say for alcohol, or I'm not sure what else, but let's just say they were given diazepam for a couple days in the clinic or in the rehab center, and for whatever reason, you're doing a urine test or somebody's done a urine test and you're looking at the results and you see 3 weeks later temazepam, oxazepam, or just oxazepam, they are not necessarily using another benzodiazepine now. It's likely the metabolism of the diazepam, which can take about 4 weeks to come out. We see diazepam, nordiazepam, temazepam, and oxazepam in that order. And so if you're sending the urine away and you see it, and sometimes they need to know from a workplace perspective, you need to write a note to say that they are fit for work and they're not using any substances anymore, and you're seeing this and concerned about it. Don't be. It will clear. You just have to give it some time. That's kind of the big one there that I wanted to point out. So where are we for time? Okay, good. So I want to talk a little bit about time frame of detection. And I'm happy to provide these charts to you if you want. So you can just email and I'm happy to send them to you. What I've done is, based on these studies and a whole host of other ones, but these are the main ones, taken the substances to see what the time frame of detection is. How long are we seeing a positive test for? What I will tell you is that it is very different from an irregular user to somebody who's been using heavily and chronically for a long period of time. And that's for a few different substances, mostly the ones that are lipophilic. So cocaine has a component of it that is lipophilic, and with daily chronic use, especially with crack cocaine, where people have been using it regularly and multiple times per day, that whole idea that it's going to be cleared out of your system in a couple of days, it's not. It may take up to 10 days or longer. And so if you continue to see a positive and the patient says, look, I haven't used, and sometimes my patients, they want to see that the test is negative. I mean, I don't need to see that. I can see eventually it will be. They get very upset by this. And so, if I've said to them before, well, it should only last positive for 3 or 4 days, and we're 10 days later and they're still showing positive, that's a little concerning for the patient, usually, sometimes for the physician as well, or the healthcare provider. But it will test positive for 10 days or longer with that very, very heavy use, especially if it's been going on for a long time. Methamphetamine is the same thing. So generally speaking, even with like a one-time use, it should be out of the system by 24 hours. In a chronic user who uses kind of here or there, it's 2 to 4 days. But there are reports of those very heavy users, many of our patients who've been using for a long time in very high doses, up to even a week. So these are really important. It's important when we're talking about it with our patients. It's sometimes important for our patients to be reassured. And it's important if we have to provide the interpretation of what our test is showing, to another party or, somebody else. It's really important that we understand that these substances are going to take a lot longer to come out for many of our patients based on the history of use, the chronicity of the use, the amount that they're using, the dose that they're using, the frequency that they're using it. So the other big one is, codeine and morphine, depending, and oxycodone will also depend on whether it's the short-acting or long-acting versions of the medication. So codeine contin versus codeine. We don't use a lot of codeine contin, but nonetheless, I'll put that out there. Cadian versus, short-acting morphine. For oxycodone, let's say a Percocet versus Oxyneo, like the long acting. So those will take longer to come out, the long acting. And the longer you've been using the medication or the substance for it, the longer it's going to test positive. And so I'm never alarmed when it hasn't come out. But again, it's about understanding it, counseling, talking to our patients about it, reassuring them. Often they're really upset that it's still showing positive because they want you to know that they are being honest. And, so I usually will ask them before I even look at the urine result, but it's often them that really want to know. Fentanyl is interesting. There was one study that showed a positive fentanyl, it was actually norfentanyl, up to 26 days after the individual stopped using fentanyl. This was a, very, a person who had been using for a very, very, very long time in very, very, very high doses, had gone into a facility where they were doing monitored urine screens. And this, average is about 2 weeks, but in one particular person, it was up to 26 days. So again, don't be alarmed if the patient is saying, like, I've stopped using fentanyl, I'm not using it, and a couple of weeks later, it's still showing positive. Again, if they were using very frequently, and especially in the fentanyl that we are seeing, we can continue to see the positive tests for a little bit longer. I mean, obviously, if it's not fentanyl that they're using, then we're not going to see it. But if there is a good amount of fentanyl in the fentanyl that they're using, then we may see that. Cannabis is the other one, although I'm not sure that we're all too concerned about cannabis use, but just in case you are, it can be up to 10 to 12 weeks for a very heavy daily user of cannabis for it to completely clear from the urine. And so understanding all of this really helps us to explain it to our patients or explain it to their family members. I sometimes have family members who come in and the patient has signed consents and they want them to know that they're not using something, but they'll say, well, they told me they stopped using on this date, but it's still positive on that date. And it's really important to be able to say, yep, that is not, those two things can still be both true, right? Because we can sometimes still see it positive for a prolonged period of time. And so the most important thing about drug testing is understanding what we're doing, why we're doing it, what questions you have that you need answered, and whether the test that you're doing does answer it. I will say that that's for all tests that we order as healthcare providers, but certainly for a urine test. So, in some of my patients, I may do very, 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 very infrequent urine testing for them. Again, they're coming in, they're telling me what they're using. there's no other reason for me to verify that. And I may not do a test. Sometimes I do it again, just for counseling, just to talk to the patient, talk about the contaminants, just so I can say, hey, look at this is showing up and this is showing up. I do that, but I don't maybe need to do it very often. Other times we do want to send it to the lab. And then if you want to send it to the lab, is it important that you know whether there are low levels or levels that are, levels that will show that there was personal use? Or do you want to see what all the metabolites or contaminants are, or very rare medications, or not rare medications, but medications that you don't see in that drugs of abuse? If you want to know whether those are there, then order that broad spectrum toxicology. If you want to see, I don't know, they're taking their Seroquel or Trazodone, or if that's important to you, or their SSRIs, or whatever that may be, order the broad spectrum toxicology panel. Make sure that what you're looking for is tested, and it will just tell you if it's positive or negative. That's how they do it. It's a confirmation test, but it's just positive or negative. And again, if something doesn't make sense, then look into what are the cutoff levels, what are we testing, what was the test that was done, and that goes for both the point of collection test that you're using or point of care test in the office, to what you're doing at the lab. Call the lab and ask questions if you want to know, because they do change things. I didn't know that they changed the cutoff levels for broad spectrum toxicology, and this is like my world. I live and breathe drug testing. I didn't know that they did that from a medical perspective. And I didn't know until I started asking questions. And so I think sometimes our labs, from a medical perspective, will do things. I called Dynacare and basically put in a request and said, on every result that's going to us as physicians and healthcare providers that are ordering this, you really need to outline on there that these are very low cutoff levels, that they're almost at what we call limit of detection, that there's going to be other reasons why someone may test positive. They didn't quite do that. They instead gave the link to the list with the cutoff levels, which is great, but you have to see it. It's in little tiny writing. Look at it and go to that site to be able to actually see it and understand it. So again, important to ask questions when things don't make sense or you're not really sure, when there are major discrepancies and there are consequences to that. So again, if there's discrepancies and it doesn't matter, it doesn't matter. Sometimes it matters to the patient and not you. Sometimes it matters to you and not the patient. And sometimes it matters to a third party. But if you need the answers, then ask the questions. All right, so what do we not? We've sort of talked about what we can tell from a drug test. What do we not know? I'll have different, whether it's a workplace or whether it's sometimes from a childcare perspective. Well, are they impaired? Does the drug test show that they were impaired when they were in with the child? Well, I can't tell you that. A urine test only tells me that the substance was in the body, and I can tell you that time frame of when it was taken, but you can't narrow it down. I don't know how much they used. Does not matter if you get the quantitative levels. You cannot tell how much a person used. You cannot tell exactly when they used, only within that time frame. So it may have been at the end of that time frame or an hour or two before the test. You cannot tell how frequently they use a substance based on one drug test. You can't tell the history, how long they've been using for. You cannot tell the route of administration. Do they inject it? Do they smoke it? Do they snort it? Do they eat it? You can't tell that. And so, I will often get asked all these questions and I say, well, I can't tell you that. There is nobody that can give you that information other than getting the history from the patient. And sometimes that's not reliable. Sometimes it is, but the drug test isn't going to tell us that. It's simply going to tell you that that substance is in the body, that there was enough to produce a metabolite either above that set cutoff level or at those very low levels. We can talk about, risks and impairment issues when it comes to substance use in general. Do I have concerns if, my patient's using alcohol all day long with respect to driving? Yes. Do I have concerns with other substance use with respect to driving? Yeah, sometimes. And so we can look at risk, childcare, we can look at risk, but we cannot with definitiveness say, yes, they were actually impaired. They were not able to drive or childcare or work or whatever that may be that they need to do. So I think I left a good amount of time for questions. And so I'm going to stop sharing right now. My email is there. Feel free to email me. I'm always happy to answer any questions. So I'm going to stop sharing. Hold on. There we go.
And thank you so much. Okay, please continue to put your questions and comments in the everyone chat. And if you want to ask your question directly to Melissa, raise your hand and Laura can unmute you. I'm going to go back to a question that came up early on in the talk, which I think is a really relevant one. Why is the lab setting those levels so low for detection, other than just because they can, if they're really not clinically relevant?
Right. So it's a really good question. And I have a very, very good working relationship with Dynacare, just from all the other work that I do. I called my contacts there. I called the certifying scientist. I called the director of the lab. And I said, this is ridiculous. Like, why would you guys be doing this? There are so many negative consequences. And I gave them all my examples because I had about, 5 examples of negative consequences from, and even if there wasn't a third party, like it doesn't make a patient feel very good when we are saying that your test is showing positive and you must be using A, B, C, and D when they're really not. I mean, that's a big problem as well. So why are they setting it? I asked the question. I didn't get a good answer. They said, well, from a medical perspective and a clinical perspective, it's important that they know if there's anything in their system, which I wholeheartedly disagree with. But they're not changing it. I asked them to. They refused. So I don't have a good, it's a great question. And I asked it myself, but I don't have a good answer. They didn't give me a great answer. I think they can test it. They felt clinically that people want to know, but honestly, I believe it is leading to, because if it's just for me, it's got to be for everybody else. Like even in the hospital, right? They're sending it for broad spectrum toxicology tests, and they're seeing things, and people are reporting to CAS, and whether it's a pregnant mother who's just had a baby or someone who's in the hospital for something, there are negative consequences to this. And I think the lab they didn't want to just listen to me. So if you feel that you want to write to the lab and call them and speak to them and tell them all your ideas of it, maybe they'll change it, but right now they're not.
Yeah, it seems hugely problematic. I have to say I wasn't aware of that. And when I'm ordering, I typically do order broad spectrum rather than specifying drugs of abuse. And often it's because I am wondering whether there's a medication that's cross-reacting that is prescribed or not prescribed. So I feel like I have to really rethink that and kind of that reflexive ordering. I think you said this, but just to clarify in my mind, this is Dynacare. And do you know how the Life Labs cutoffs compare?
I don't. I tried to call them and ask them in preparation of this, but nobody got back to me. I tried to look online. I couldn't find it. So I don't know. I do know that they have broad spectrum and they have drugs of abuse as well. If you use Life Labs, like if that's the lab that you send to, honestly, just send them like send them an email if you have a contact, call them. If you're a client, they should answer you. They didn't answer me, but they should answer you as a clinic or as a healthcare provider who's sending stuff to them, and ask the question. They'll have the answer for you, but I couldn't get it in time for this. So.
Okay, thanks for trying. I think it's absolutely worth following up on. A question for folks who use Kratom, then it would make sense to send this sample for broad spectrum rather than drugs of abuse. But I guess the question is, maybe jumping off from there, what is actually not captured even on broad spectrum? And the one comes to my mind that I had a patient using was phenibut for quite a while. And so I'm wondering, what else should we be
Yeah.
thinking about in that same vein?
So the broad spectrum list changes as the lab's ability to test for it changes. So they're always updating it. And that's why it's really important to look online to see what that list is now, because it's different than 6 months ago, or it could, in theory, be different than 6 months ago. There are a lot of things that our patients are using that will not show up even on broad spectrum. And again, it actually could differ lab to lab. So it's possible, I'm not saying it is for sure, but it is likely possible that Life Labs and Dynacare has slightly different substance abilities to test and confirm on their broad spectrum. So just look at the list and see. And it, like I showed you the list, that is current as of last week. That's the Dynacare one. But you just look on that sort of link there, that's at the bottom there. And I'm sure that Life Labs has the same link that you can look to see exactly what's tested so that you know. And what's not there is what's relevant. But I don't want to go through the list of everything that's not there, but there's a whole bunch of things that our patients use that are not tested. And it's mostly the lab's ability to actually confirm it with mass spectrometry testing. So, it comes and goes just as substances do with our patients.
Are there some key ones to think about, though, that you're finding people are using that are not detected?
Um,
I feel
I
like most of the other party drugs and things show, I'm calling them party drugs. That's probably not
Many
the
are
right.
not there's a number, there are a number of, like I'd have to actually look to see if, because last time I looked, I don't even think psilocybin or psilocin was, that they were testing that. Um, it may have changed. So I don't want to say, I don't want to tell you that I don't want to like give you the ones that I think because I don't have the list in front of me, but I'm happy to send you the list or just look at it and see and go through. But there are a number. And so, for those ones, even if I get a negative test from the lab and the patient's telling me that they're using something, I will usually just look and see and think, oh, I don't need to send it to the lab again because they don't even test for what they tell me that they're using.
Right, right.
Yeah.
And they've told you that that's what they're using. So
Yeah.
unless you're looking again at sort of contaminants.
Yeah.
One of the questions was about common causes of codeine positive result, and I'm imagining this could be generalized to a morphine positive result. Let's start with a point of care test. And I think, again, you talked a little bit about the opioid metabolites. Maybe you could come back to that, and then some non-opioid use causes of a positive opioid.
Okay, so I'm actually going to use a little cheat thing here and look. I have one of the. Hold on, let me just look here. So okay, so let's talk about a couple things. First of all, um, there are different substances from different cultures, I will say, I don't even, or different countries, if somebody gets something from a different country and brings it here and uses it, that have codeine and morphine in it. There's some Ayurvedic medications that people take that is morphine and will have morphine in it. It's opium basically. And so we see it positive for morphine. And when you ask them, are you using morphine, heroin? No, 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 no. But they may be using something from their home country that can contain that. So I always ask about, supplements or, medication from wherever they're from. Does somebody bring something back for you? And again, it's not necessarily a punishment thing, but it's like, let's try to figure out what's causing a positive test here. Codeine is almost always codeine. And again, if you're sending it to the lab and it's on broad spectrum, that codeine cutoff level is super low, and it may actually be from poppy seeds. That is a thing. Poppy seeds will test positive for morphine up to 4,000 nanograms per mil. You can see very low levels of codeine as well, usually in the less than 100 or 2. But that broad spectrum is testing it at super, super low cutoff levels. And so we can see it. On our dipsticks, on our POCT, our codeine levels are generally set higher. And so you may not see codeine from poppy seeds, but you certainly can see morphine. And especially if they had it that day, not if they had it a week ago. And sometimes, again, it's like a mixture from their home country. Sometimes it's a Tim Hortons everything bagel, which will do it if they had that in the morning of the test and then they came in. So, I will, if it's a concern for whatever reason, you can send it to the lab. and see. But it is a thing. It's like it can happen.
Interesting. I've always said it has to be like a lot of poppy seeds. Like I wouldn't
Well,
be
if you
important.
have one everything bagel from Tim Hortons in the morning and you come in and leave a test, you will test positive for morphine below 4,000 nanograms per mil. So, and that's not even so much. It depends on where they're getting their poppy seeds from. And so, yeah. So I just say to my like, if I really think that's what it's from, I'll just say to them, like, just don't have the bagel before you come in, have it afterwards. And then let's see, and then miraculously they don't test positive. So unless you're getting the quantitative levels, it's really hard to see. If it's above 4,000 and you get the quantitative levels, it is not from poppy seeds, not.
Amazing.
Doesn't matter what unless they're like having massive doses, but yeah.
Okay. I'm going to move a little faster because I can see questions coming in and I have some. Dynacare's toxicology test reports alcohol, not ETG, which is ethylglucuronide. Can you make any conclusions about what a positive test means? My experience is that patients have to drink several drinks the evening before or drink something on the day of the sample they provide for it to be positive. Concern about this, being showing up as a positive and possible problematic alcohol use if that's routinely positive and it's routinely reported.
So you can request ETG and ETS from the lab. As from a medical perspective, we can if you need to know that. If you are seeing ethanol, they had alcohol recently enough. Okay, so if they come in the morning, so it could be from the night before. If they wake up in the morning, come right to the clinic and leave a urine and they have not peed at home before, for lack of a better way of saying that they haven't emptied their bladder, it can be from the night before. Short of that, if it's 3 o'clock in the afternoon and that's when they left their urine and it's positive for ethanol, they had alcohol sometime between the hours of when they last left a urine, like they last emptied their bladder and when they left the sample. And so if you are continually seeing ethanol positive, there would be a concern for problematic alcohol use and likely alcohol use within hours of that test. The only caveat to that is that in a patient who has very high levels of glucose in their urine, you can also see ethanol. The lab will usually report if there's glucose in the urine as well, because when glucose is in the urine in very high levels and the urine sits for a little while, especially in warm temperatures, we see the production of ethanol. But otherwise, if you're seeing that and you've ruled out that there's no glucose in that urine, then it is problematic alcohol. And that's when we start the counseling with respect to alcohol use.
Yep. Thanks for that. A question about very faint lines on POCT and what you're going to call, what you're looking to call something a positive or a negative.
So faint line is positive, as long as that faint line comes up in the first 10 minutes. So, if you're looking after 10 minutes and, an hour later you happen to look at it and now there's a faint line, I would not necessarily say that that is positive. A faint line within the first 10 minutes is a positive test. And so it does not have anything to do with the quantitative levels in that urine, meaning you could still have high levels and have it very faint, and you can have low levels and have it very strong. It's just the immunoassay. It's just the device. So don't put any stock in what the level must be if it's a faint line versus a thick line. And I'll have patients say to me like, well, was it a lot? I'm like, I don't know. Like, there's no way for us to know. So is it coming out of my system? I don't know. Let's just wait and see, but don't put any interpretation of that.
Yeah, I do think there is an issue with sometimes interpreting too quickly or waiting too long. I know I'm not always patient, to wait for that 5 minutes, but yeah, certainly my training was if there's a line, there's a line, but you're right. Sometimes it is very faint. A great comment. Thanks, Eric. I actually diagnosed a patient with diabetes because of alcohol in their urine regularly. Well done.
Yeah.
Um, Question from Karen Leslie. I don't think you did discuss this. Parents who are using home drug tests with youth. Urine drug testing is typically not done in the youth setting. Karen's at Sick Kids. Is there any oversight regulation of the home drug testing kits regarding accuracy and anything else that you want to add around home testing?
Yeah, I have a bit of an issue with it because many of the parents are buying stuff online where there's no quality control or oversight. And so it's the same thing. Even in the best case scenarios, and we are all buying like Health Canada approved devices, what most people are buying online from Amazon are not Health Canada approved devices. So in order for it to be a medical device to make a diagnosis, it needs to be a Health Canada approved device. Ours that we use clinically are, or they should be. I'm going to make the assumption that we're all using that. What parents are often using is not at that level. So what I will tell them is, I'm not necessarily condoning doing testing on your children, but if they are, or they have an agreement or whatever that may be, make sure they are buying Health Canada approved devices. There's a list online of all of the manufacturers who meet those standards, and I would not use anything else. It's just, there's no way to know what you're getting. There's no quality control. There's no oversight. I wouldn't trust it at all. So I would really stay away from anything that is not. Obviously, the Health Canada ones are a bit more pricey than what you can get on Amazon, but for good reason.
Yeah. And then, of course, there are all of the other associated issues around who is asking for the testing and, yeah, consent, permission, monitoring, conditions, et cetera, et cetera.
Right.
So,
I don't want to get into that as a whole other conversation, and we can give a whole talk on that, but um, I know that there are parents that do, but I always say, like, don't, like, if this is what you're going to do, just be very careful of what you're purchasing and where you're getting it from.
I just wonder if we could jump from that for a minute. I know, you're involved in forensic testing for monitoring purposes, and I wonder if you could just explain a little bit about the how forensic testing is done, what chain of custody means, and how it's reported. And I'm thinking primarily, well, I guess we all have some patients who could be monitored in the workplace, but I'm also thinking about PHP and NHP monitoring, just so
Right.
people understand a little bit about what's involved there.
Yeah. So for any kind of monitoring. So whatever that may be, it is really important that the tests that we're doing are under that forensic category versus clinical. It's not to say that the clinical ones, even from the lab, are wrong, but we kind of send it, it gets picked up and it goes, and who knows what happens to it in between. What is the difference? Through PHP, through whatever it may be that we are monitoring a urine and we're doing it under that forensic category, there is a collection if it's urine. So they don't do observed testing. We really almost never do observed testing in Canada. I don't want to say never because I heard of one company that's doing it, but we don't usually condone it. We don't usually see it. And I certainly wouldn't recommend it for any kind of monitoring in that case scenario. But they'll blue the water in the urine to make sure that that they're not taking water from the toilet bowl. There's no running water. So again, they can't fill the urine cup up with running water. They temperature test it to make sure that it's at body temperature. They do integrity testing on it at that time, which is with adulterants to make sure that there's no adulterants in it, that the creatinine is within normal limits, meaning it's probably human urine versus, apple juice that has no creatinine in it. They then fill out a 5-page form. One is for the collection site, one is for the lab, one is for the medical review officer, one is for the person leaving the test, and one is for the company or whoever is ordering that test. And everything on that sample is labeled with a barcode. So the urine is closed with a sticker with a barcode on it. It's signed by the individual. It's packaged with the barcode on it. It is sent with FedEx or UPS. It goes directly to the lab. The lab can literally track it from the time it has been picked up to the time it's delivered. So you will get the exact time of pickup and delivery at the lab. And then from that moment on, you can follow from the lab each and every single step until when it's reported. The difference between that and what we do is that while the lab can tell you approximately when the delivery came, there's just There's no seal to it. We don't seal them. I mean, you know, we can't tell that somebody opened it up and added something, did something to it. I mean, probably the UPS driver didn't do anything to our patients' urines, but in theory, somebody could have. We don't have that sticker over it to tamper-proof, you know, really tamper-proof it. And we don't follow it all the way through. Like they can kind of tell us, like once it gets to the lab, they will tell us what happens to that sample, but it's not treated with the same level of detail. And the set cutoff levels are also different from a forensic perspective than they are from a medical perspective, as we can see. Forensic are set much more so with respect to personal use, with multiple studies speaking to the fact that if it is positive at that cutoff level or above, that there has been use within that time frame. And so that, you know, to me, really, if even, I mean, CAS used to do, they used to do a lot more forensic testing than they do now because of budgets. Now they're getting us to do testing for them, which is not really what we're supposed to be doing, nor what they should be doing. But, you know, I can't change that. So, yeah.
Yeah, but your description really highlights all of the different ways in which these samples could be challenged, are fraught, and why they should not be considered to be accurate for those kinds
What
of
I will
cases.
say is that if this is anything that's going to end up in arbitration or court, it should never be done from a medical perspective. It should always be done from a forensic perspective.
I want to jump to something that's a question of mine, which is methamphetamine use, urine testing, and patients on stimulant medications for ADHD,
Yeah.
and what crosses over and what doesn't.
Okay. So, okay, I'm going to talk about lab first, and I'll go to our POCT. So from a lab perspective, the medications that we see that will test positive for amphetamines only at the lab. I'm going to use the brand names. I know we're not supposed to, but honestly, I can't remember what the generics are. So I'm sorry about that, but I'm just going to use the brand names. So Vyvanse, which I think is lisdexamfetamine, Adderall, which may or may not be amphetamine salts because I can't remember, and Dexedrine. If they are on Ritalin or Concerta, they will not test positive for amphetamines. Will not. So if you are prescribing Concerta and they are testing positive for amphetamine from the lab, it is not from their Concerta or Ritalin. From what we are doing in our clinic with our point of care tests, you have to look at your product insert. Some of the amphetamine medications, those 3 medications, will test positive for methamphetamine if there's high enough levels on some devices only, not all of them. And so it is possible, in theory, if you're giving somebody a prescription for one of those 3 medications and you do it in the office and it tests positive for methamphetamine, that it may be from their medication, but you have to look at that device product insert to see whether or not it cross-reacts with amphetamine.
You don't think this will ever test positive at the lab on
Never,
confirmatory testing?
never, never. Because methamphetamine metabolizes to amphetamine. Amphetamine does not metabolize to methamphetamine. So at the lab, you will not get a confirmation for methamphetamine due to amphetamine use. Like, yeah. Nor will you get a positive for amphetamine if they're using or prescribed Concerta or methamphetamine for that matter. You will get Ritalinic acid on that broad spectrum, but you will not get anything else. And so if you're seeing methamphetamine, it is 100 from the lab. It is 100% not from those prescription medications. The metabolism doesn't go that way.
Thank you. It's something that has come up again and again over time, again, with people being adamant or trying to choose a medication for their ADHD that won't show up as a methamphetamine in order to be able to distinguish. And it's
Yeah.
very definitive. Thank you.
They're 100% from the lab. Methamphetamine is not from any of those medications. The only thing that will result in a methamphetamine, there are a couple prescription medications for Parkinson's that are methamphetamine. They're L-methamphetamine, not D-methamphetamine. And the generic Vicks inhaler, the nose inhaler from the US only, not from Canada, does have L-methamphetamine in it, not the Canadian one. So if they tell you they're using Vicks because they looked it up online, ask them where they bought it. If they tell you in Canada, it is not because of their Vicks.
Okay. Don't buy Vicks from the US.
Yeah.
Katie asked a question because of everything that you've shared. Do you ever choose a treatment based on, I guess it's not difficult or easy, I guess on the accuracy of the test interpretation?
Sorry, say that again. Do I choose?
Do you ever choose a treatment based on how difficult or easy it is to interpret the tests?
Oh, I see what you're saying. I think it depends on, I mean, generally not, but I think it depends on what the circumstance is. So I can't even
Ritalin
think.
versus Concerta, diazepam
Right.
versus.
So, for example, if I had a patient who said to me, I want, like, I get tested in my workplace, okay, and I know I just don't want it to ever show up with anything because I don't even want them to know I'm on any medication, and I don't want any of the stuff for my ADHD. If they had Concerta or Ritalin, it wouldn't test positive. But generally speaking, even if they are being drug tested in their workplace or through PHP or through monitoring of some sort, if they're a nurse, if they're whatever it may be, and they're going through monitoring, if you have a prescription medication that accounts for the positive test, it gets verified as a negative test to the employer or to the person that they're verifying it or monitoring it. So it shouldn't matter, but sometimes it does the patient. That would be the only time that I can think of, to be honest. It's just really about understanding what you're looking at, like what the results are, and when you're ordering the test, what you're expecting to see versus what you're not.
Yeah. Yeah. And to your point, what's the significance of all of that?
Hmm.
Thank you so much. I imagine that we will have requests for some of those metabolism charts and especially sort of the cutoff times. Yeah, really interesting how long fentanyl, benzodiazepines, and cannabis can stay positive. You didn't mention anything about nabilone and whether that shows up as a cannabinoid or not. Last,
It will not. It will not.
yeah,
Marinol, which is no longer available in Canada, does. Sativex does, not Nabilone. Not a
thank you,
positive for THC. Yeah.
which is great. Do you share results with employers? Katie, you have so many questions. This is great. Um, or do you share a summary in your own words? Last question.
What? Sorry.
Do you share the actual results with employers or do you summarize and interpret them in your own words? It's a great question.
Um, for employers, when they're doing drug testing, they use a particular panel based on the company, and they get reported as positive for that substance. So they don't just get a positive test; they'll get positive cocaine or positive cocaine metabolite, positive fentanyl, positive whatever it may be. Um, if if they ask for an interpretation, then a person who is able to give that interpretation can give it, again, with that time frame of detection, depending on what type of test they're doing. But it's not just necessarily positive or negative. It is positive for this or positive for that. And again, if they have a prescription medication, it gets verified negative. So it's reported to the company as a negative test.
Yeah. That's great. Thank you. Thank you. Thank you. I think Lori might pop up the schedule for the next webinars. Again, third Wednesday of the month. The next one is on low testosterone, hypogonadism and testosterone replacement. Then we've got one coming up on Hep C and then on smart recovery. Quick messages, register for CSAM. It's in Hamilton and there will be an entire Medify day and Medify group there. We'd love to see people. We'll be sending out information and invitations to submit abstracts for the Medify conference very shortly. Melissa, that was really great. Thank you. Very informative. Will change my testing patterns around drugs of abuse versus broad spectrum, I'm sure. I'd be much more, yeah, sort of thoughtful about what I'm getting from one versus the other. Thank you to whoever shared the link to Life Labs, and I think that's really important. But I think a huge takeaway was know your lab, stay up to date, look at the insert. There's a lot of fine print there, but it's worth checking it out periodically.
Thank you,
Thank,
everybody.
thank you so much.